Hi everyone, thank you for joining. I'm going to go ahead and mute all lines and then we will begin the webinar.
The leader has muted your line. To unmute your line, press pound 6.
Good afternoon, everyone. My name is Leila Blinsky. I am a Senior Program Administrator and the New England Regional Lead for the Quality Payment Program work at the New England QIN-QIO. I want to apologize just briefly. I was traveling earlier this week and I am a little congested, so if I clear my throat, I'm sorry. Today's webinar will be talking about data scrubbing and quality improvement, focusing on how you can evaluate the quality of your QPP data and prepare for reporting. Just briefly, many of you who have attended these webinars before have seen this. We are CMS contractors, but the content in these slides was created by us. Quick overview of what we'll talk about today. I'm going to just briefly touch on the 2017 data submission timeline, and then we'll dig into data scrubbing, some key elements of reviewing data reports. I won't actually be showing you data reports. Again, a lot of that information is protected. Oftentimes, the practices don't want to share that publicly. So we'll just kind of be talking high level about what the concepts are that you need to have in place when you're looking at your reports. And then if you have more specific questions, just know you're more than welcome to contact us. You can either send emails directly to my contact information at the end or reach out to the New England QIN-QIO and we'll target your right state representative. I'll then be talking about quality improvement strategies. We'll touch on the PDSA cycle, workflow analysis, root cause analysis, and talk about some concepts you should consider when you're doing your provider education. We have some resources at the end, and of course, plenty of time for questions. Some acronyms. I won't go over all of these. You've probably all seen them many times, but CMS does love to use lots of acronyms, so you'll hear me mention them. I typically explain what they are the first time I say them, and then you'll hear the acronym after that. We're going to do a quick poll. Of those of you who are on the line, are you planning to participate in the quality payment program this year? So for 2017 data, if you're part of an ACO, are you reporting through the APM or are you reporting to MIT? If you're a group administrator, are your clinicians planning to report? So if you could just take a moment and answer that, I would really love if everyone doesn't mind answering it. It just really helps us know how everyone's doing as they plan for the next year. Great, poll is closed now. Just wait a second to see what the results are. They're not actually showing up. Anyway, we'll move on. So for 2017 data submission, those of you that are using the CMS portal or registry, let's see. Oh, not many of you answered. So a few yes, a couple no's, and a couple unsures. Okay, thank you. So for data submission, if you're using the portal or a qualified registry or a qualified clinical data registry or claims, you have until March 31st to submit your data to CMS. That is the final date CMS will accept your 2017 performance data. Please keep that in mind if you're waiting to aggregate your reports or pull data or whatever the case might be. That timeline is shrinking quickly. You have about a month and a half left. We do want to make sure that you all have data submitted so you don't get a negative penalty on your Medicare Part B claims in 2019. Of course, if you have any questions, we welcome those. We want to make sure that you are all successful. If you happen to be part of an APM or a large practice that's using the CMS web interface, your submission window is a little different than the other tools. You do have between January 22nd and March 16th. So that's a bit smaller. Just make sure you have those dates in mind. You do have only a month left to submit data if you're using the web interface. So, what is data scrubbing? I'm going to add just a quick bullet point that's at the bottom, not in very large text. Some of you might be familiar with data scrubbing in terms of database maintenance. We're not going to be talking about data scrubbing in that way. This is more how are you analyzing and reviewing the validity and accuracy of your quality data reports. So are you looking at them how you track your numerator and denominator populations to make sure that they're accurate to the patient population you service, to your practice. The measure has a specific population with maybe a disease condition. You know roughly how many patients you should have, and does that look accurate? We'll also talk about elements, data elements that you should follow. Practices really should have in place with their organization or just in the practice itself, a data dictionary and a specified workflow that's followed and agreed upon by all members of that practice. So, some different measure types and reporting tools. The first we'll talk about just briefly is the electronic health records, so EHRs. If you're using an electronic health record, oftentimes that EHR can pull data for you based on the measures that you have submit data on. Oftentimes that has to be documented in discrete fields, so those are fields that would be checkboxes or drop-downs. Those would not be free text notes or comment fields because the free text notes cannot be easily combed for data to support reporting. The next we'll talk about our registries or qualified clinical data registries. For the most part, these function in the same manner. You would be submitting data to the registry. Either that would be a manual upload, or sometimes the registries have interfaces into an EHR system and can automatically pull that data right out of your system. The key component of these to consider is that this is only the data that's included within that registry. So it's only whatever you submit to the registry that can be supported for reporting. If you would like to report on a larger sample of patients or patients outside a specific disease condition, you might need to look for other reporting mechanisms. The last reporting tool that we see clinicians use is the manual data report. So that's often in an Excel or some other spreadsheet type of format. Again, this is only data that is included in that report. So if you're tracking your patients manually, perhaps they're still on paper or you don't have a robust reporting system within your EHR, you would only be able to report on the patients you have data in that spreadsheet or Access database or whatever tool you're using. And then it's a very manual process to pull that out. You have to do filtering and different lookups. But we can talk about that if that's your tool and you need help with it. Next, I just want to touch on the different types of measures. Any of you that have participated on previous webinars have probably heard us talk about what's required in order to have full data reporting for the quality measures. Under the MIPS program, so the Merit-Based Incentive Payment System, and under that program, you are required to have at least one outcome. This is if you're going for full reporting outcome measure, and they look for high priority measures as well. So we'll start at the top. A process measure is determined by services provided to patients in a consistent clinical manner. So oftentimes those are the screening exams. So did the patient receive a colorectal cancer screening? Did the patient receive a flu shot? So an example here is, does the provider ensure that all patients have received their flu shot? So it's just a process. Did this happen in order to make sure they've gotten the care they need? The next is an outcome measure. These evaluate the health of the patient as a result of care that's already been provided to the patient. So it has to have a process in place in order to achieve that outcome. So it's really twofold, but you're not measuring that initial process. So an example here is, what's the amputation rate for patients with diabetes? Another common outcome measure that's often used by practices is the hemoglobin A1C for control. That's actually an intermediate outcome measure. But you're looking at the patient's A1C based on the control and the other clinical activities that have taken place, and have you been able to obviously lower that A1C for that patient population. The next, patient experience, is just what it sounds like. This is looking at feedback from patients. This can be taken oftentimes as qualitative results, not as much the quantitative results, but it does look to see what was the patient's experience with maybe the communication of a specific provider around the care plan, or how did the patient feel about their clinician's bedside manner, or how they address concerns, whatever the case might be. Some practices use the HCAP or other Press-Gini surveys to pull that patient experience data. It doesn't have to be something you create. You can always pull in that data from another source. Structure data, we don't see too many of those measures in the MIPS program, but that does assess the characteristics of a care setting. So that's looking at facility staffing, other policies around the delivery of care. An example would be, are there adequate staff in the emergency department when there's an event going on in town? So did the staff cover the fare adequately? That's just an example, giving you some ideas around what those measures might look like. Next, I want to talk about two really critical elements about your report. So the data reports that you pull really need to look at two things, timeliness and frequency. So when you think of timeliness, what's the lag between the data, either the entry of that data or the data collection and the reporting? So if it's just minutes, you have a patient come in, you enter their vital signs, and you immediately report out the patient has a temperature, obviously there's no lag there. However, if you're using systems that are a little more manual, perhaps the claims-based reporting route, there is a tremendous lag in when you submit your claims data to CMS and when you're actually able to see reports on that. Now, if you have a billing system that can more quickly report on the claims you submit, then obviously you'd be able to have more timely data. But for the most part, claims is a very lengthy process, and it does take about 3 months to get the data back into the system and able to report on. So I have an example here. Reports that depict the process over 2 quarters later might no longer be accurate. So think about a process that you put into place. Sometimes, obviously, you're monitoring it to make sure it's stable and you have all the things you need in place to keep it going. But if it's after the fact, clinicians sometimes get right into the routine and they really stop thinking about what got them there. So it's important to keep that very timely and try to keep that data fresh. Frequency. So how often are you running these reports? Clinicians and staff often need to have the data in a very timely manner, so you need to be looking, do I need to report these measures to the clinicians in a monthly report? Maybe in a weekly staff meeting, you bring up, this is your rate for this measure. If it's patient experience, it might take a little while to get those surveys back, but that's also a great thing to have in a very frequent staff meeting type format or monthly all staff meeting format where you can really talk about and dig into the details of maybe where certain clinicians are not performing as well and look at how to benchmark against clinicians that are performing better and put those changes into the workflows early on rather than waiting until the end of a year-long reporting period and saying, ooh, this clinician really didn't have the data to support it, or they should have looked into their workflow earlier and now it's too late to correct that. Again, one thing we hear a lot of is clinicians obviously are very burdened with reporting and documentation, so be mindful of data overload. If you dump a 20-page report in front of a clinician on a monthly basis, you might lose them, so think kind of strategically about what measures you're selecting and how often you present them to those clinicians or groups of administrators. Just some quick considerations for data. So what are the requirements and are they known? Do you know what measures you're reporting on and do you know the patient populations? Has your data collection process been designed? Oftentimes we hear people say, well, I just go into my EHR and I click the button to run this report. But there really isn't a process, and so you do get into that place where there is data overload because you're getting all this data in your face pretty much instantaneously, and you don't really know what to do with it or how to assess it or how to make it meaningful for your clinicians. Again, has that process been implemented for data collection and has it been communicated? So do your clinicians know how often they'll be getting these reports? Or do your IT group know how often you'd like to be getting the reports? So it's really important to have a group discussion about the plans and the utilization of the data. And then finally, how are the reports generated and how are they analyzed? I talked about this already a little, but making sure you have a plan in place for how you're taking your reports, how you're validating them, what the timeliness is, and then utilizing it from there. Some key reporting requirements that you should be thinking about as you look at your patient populations and these various reporting types is review the measure specification sheet. They are a wealth of knowledge for patient population buckets. So when you look at your patient population, and I'll talk in a minute about accuracy and validity of your reports, But when you start to look into the populations, and if you do a very in-depth validation of those patients, you might find that there's errors in the actual back-end reporting system. So if you have a patient that perhaps didn't meet a specific measures criteria because they became a hospice patient within a day of admission, this is for admitted patients, but if that was the case, they would fall out of your population. But perhaps that wasn't documented in a way that was able to be pulled by the report, and thus that patient stayed in the population and was only in the denominator, thus hurting your performance overall. So it's really important to understand what the measures are telling you about the patients that fall into the numerator, the denominator, and any measure exclusions or exceptions. And I'll just briefly touch on what those are. So a measure exclusion would be patients that are completely excluded from the measure. So if they don't have a diagnosis, or again, they were hospice within 1 day of admission, they would be excluded from the measure. Measure exceptions are when there's a specific condition that takes place. So let's say for flu shots, there are not enough flu vaccines because there was a statewide shortage. That would be a measure exception, and you want to make sure that you document that because, in fact, the clinician wouldn't be dinged for not administering the vaccine because they didn't even have stock. The other would be potentially a patient allergy. Those are oftentimes measure exceptions, especially in the vaccination measures, because if a patient has an allergy or any of the medication measures, you wouldn't obviously want to give them that medication, but you want to make sure you document the patient has allergy, hence they didn't get this medication, immunization, whatever the case might be. Next, it's really crucial to look at the current workflow to determine alignment and if alterations are needed. Again, as I mentioned with the clinicians looking at those reports on a frequent basis, you can quickly identify, let's say you have a practice of 5 or 10 clinicians, if 8 of them are performing in the upwards of 80 to 100% group of the performance on that measure, and you only have 2 down in the, let's say, 40% range, you can quickly identify that the workflow for those 2 in the lower percentage probably doesn't align with what the other 8 are doing. And so it's really important to say, okay, what are you doing? Does it meet the measure specifications and how our system is set up to capture that data? And if alterations are needed, let's put them in place and make sure everyone's educated on what's needed and go forward from there. Additionally, if you're using an EHR, potentially a qualified clinical data registry or qualified registry, you need to make sure that you're following the specific workflow that's supported by that system. You can't usually develop workarounds because with workarounds, you might miss that crucial element of data entry that really drives getting that patient onto your report or getting the correct patient population into the report. So kind of connecting all the dots and working through all the systems really is crucial to make sure your populations are correct. And then determine if the data collection process is automated or manual. I talked about that already. So where is the data coming from? Excuse me. Is that from your EHR or your registry or from a manual Excel system that you've developed where you're capturing patients when they come in or whatever your other process might be? And if it's automated, again, how often is it being run? What's the time frame? What's the look back? Manual, same kind of thoughts. You want to make sure you pull the data frequently enough, but not too frequently, and that you have an accurate system in place. And then determine the best method for displaying the data. This isn't quite as much about what you're submitting to CMS, but in terms of getting physician buy-in and making sure your programs are in place, having a dashboard or some sort of graphical representation of the data is often very helpful when communicating with clinicians, because if they have to dig into the specific numbers, it can be really challenging for them and take a lot of time. So if you can give them sort of the stoplight, red, green, yellow, for how well they're performing, that often is very helpful, and they know what they need to either continue doing because they're doing it well or maybe make adjustments on. Oops, I think I skipped one. All right, so just a quick glimpse at what a measure specification sheet might look like. This is for the hemoglobin A1C pore control measure. Just to quickly give you an idea, you can see there's a denominator exclusion. Again, that's a hospice patient. You'd want to make sure you include that. And then there's different performance met or performance not met. This is for our claims-based reporting. So you need to make sure you're following this exactly the way it's laid out to enter those appropriate codes into your claim sheet so that you get your patients bucketed correctly based on whether they're in the numerator or denominator or have an exclusion and get pulled out of your population. So validation. I spent many an hour validating reports. It can be very rewarding because you see how well your providers or clinicians are doing, but it can be really challenging too because you might find that there are errors that need to be corrected. So validity is the extent to which an instrument measures what it's designed to. So in a report, it's the extent to which that measure that's being displayed is actually representing what it was supposed to be measuring. So as you start looking through your reports, you'll want to make sure that you gather enough data to provide useful information on that particular measure. So in the 2017 transitional year, there was the ability to report on a single measure for a single instant on a single patient. Obviously, one patient, one time really doesn't give you a whole lot of information about how accurate and correct your process is. If you're looking at more of like a 6 month, 3 months, even a single month time frame, you can usually get a better idea of what kind of data you have. If you don't find that a single month or even 3 months gives you enough data, always extend your time frame. So have more. It can take a little longer to validate that data if you have a significant number of patients in your denominator population, but it does give you an idea of how accurate you really are. You can measure it against, again, your patient population as a whole. So what's the panel look like? Clinicians oftentimes in smaller practices, even in large practices, really know their patients quite well, and they know roughly the size of their different patient populations. So they know about the size of their panel. They know about the size of their diabetic population, about the size of their cardiac population, and really can say, you know, this just doesn't pass that gut test to say this looks correct. And once you start running reports more frequently, you'll know roughly where your clinicians are, obviously with monthly and quarterly variations, but you'll get an idea of roughly where they are, and so you can quickly eye what looks incorrect. And then where your report's being generated. So again, going back to that sources, you'll hear me say sources many, many times. It's important to know where your source data is coming from. If you really like to dig into the details, you can look at stored procedures. That often can show you if data is being stored in the wrong area for a given measure or maybe is inaccurate, and you can go back and say, you know, this doesn't look quite right, or I think this is wrong. It's really important to vocalize concerns about where you think the data might be incorrect and get your vendor or registry vendor to start looking into that and making corrections for you. They can be very time sensitive. So it's important to look at those early on. Who collects the data? Is it one individual? Is it multiple? Again, that's where it's really important to have a process in place. And for validation, I used to do inter-rater reporting where we had to go back and multiple individuals would evaluate the same measure and we'd see if we all got the same data. So if you're concerned about the validity of your reports, it might be helpful to have more than a single person take a look and say, okay, this is correct, or this is why this patient didn't fall in, because sometimes we kind of get mired in the details, and we might forget, oh, that's right, this measure had this exclusion. And so having somebody else with maybe fresh eyes look at it can really help inform your process. Again, you'll also hear me say multiple times today about workflow. Is that specific workflow in place to ensure data collection? We've heard many a time as we work with clinicians, specifically with the EHR reporting, that they followed this specific workflow for documenting a given patient's care and different procedures that were done and follow-up that was done. However, as we start to dig into where that was actually documented, we find that they were documenting in the wrong field, and it was a workaround that was generated maybe years ago, maybe before a process was even in place, but it's really gotten kind of stuck in the routine of that practice. And when they go to report, they find, oh no, I thought I was doing this process exactly right, but when I get the data, it doesn't at all reflect how I think I should be performing. An example of this was not related to quality measures, but more going back to the advancing care information measures, and specifically the one that often causes tremendous upset for many people is the summary of care measure. So sending that summary of care for referrals and transitions of care. Oftentimes it has to be electronically. So sometimes clinicians document their referrals in a way that they send that message to maybe a front office staff member to complete the referral or do the insurance validation. And so it looks like a referral. However, that patient is in fact sort of being transitioned from practice to practice if it's maybe within a system. So the specific practice thought they were doing everything right, but when they got to their numbers for that summary of care measure, they realized they had a huge denominator. And luckily, CMS implemented an exclusion if you have less than 100 referrals or transitions within the reporting period. However, this practice had like 300 in their denominator, so obviously they're way over the threshold of being excluded. And because of the way they documented, there's really no way to retroactively pull those back. They had entered referral records on all of those patients, and so the system thought all of these patients had been referred to other settings of care, and so they were being counted. And in this example, they had very few in the numerator, so their performance was very low. Now, they would have met the requirements, but again, if you're looking at your performance, you really do need to identify, is this correct and does it support the measures or process or whatever I'm reporting on? And again, do that gut test. If you look at it and you say 300 and you know instantly there's no way 300 patients have been referred out of this practice, go back and look at the source data because it's likely inaccurate or incorrect. But then again, the source also comes from that workflow. Is the workflow consistent and is the workflow accurate to the measure specification? So checking for accuracy. We talked about this a little with validity and everything else. So does the data accurately represent the population being measured? So again, consider the sources, right? I sound like a broken record. I'm saying the same things over and over again, but this is really getting to the point of where you need to be. Is all the necessary data available is also a crucial element. Can you pull it? If your clinicians say, well, I only ever document that in my notes, well, unfortunately, if you have an electronic reporting system, either a registry or a EHR, you're not going to be able to pull that. So they're not going to be able to get credit for all of the good work that they're doing and care that they're giving to their patients. Again, talking about timeliness and frequency, consider the time frame that you're being measured. Were there changes to the workflow? So if you run a report, let's say January to March of this year, but in June you implemented a change to the workflow, well, those earlier reports won't demonstrate that change that was implemented. So you need to run another report afterwards to make sure you're capturing any of those changes. Or if you see tremendous decline in measure performance, consider how your change might have affected the reporting structure. Did you follow what was required and what is supported by your electronic reporting system to make sure you're gathering the necessary data? Talking a little about the data dictionary, is there organizational agreement for the data elements being measured? Oftentimes we see clinicians all have different ideas about what's being measured and what is. They all have different thoughts on the various elements of care. So utilize a data dictionary that's consistent across the organization and has been agreed upon. Having data that's structured really does help make the reporting process run much more smoothly. Has the measure specification sheet been followed to identify those patient populations? So again, as I showed you with the A1C measure, it's really crucial to follow it. Was the patient in the numerator? Was the patient in the denominator? What care did they receive? Where's the lab result? Looking at all those elements and kind of tracking it down, following the path to make sure you're pulling the patients appropriately. And then again, do that gut test on your data report. Are the numerator and denominator populations aligned with what you know to be true in your patient population? Again, if you look at it, and let's say you only have 10,000 patients in your entire practice, and you have 5,000 of them in a given measure that really only should have a handful, you know that the report probably isn't accurately pulling the correct patients. And then, again, consider reviewing all source data to ensure that it's complete. If you submit data to a registry, and if that's a manual upload process, or even if it's pulled from an interface, make sure that you're evaluating the correct data. Sometimes there's a lag, again, in how those systems pull the data from your system or from your upload. Make sure you're looking at the most accurate and up-to-date source file, because they might not have yet been implemented into your system. Consistency, I just touched on that, but are the same measures in the same practices being collected the same way? Again, clinicians across multiple practices often have different interpretations of how to do their workflow. A great thing about electronic systems and even the paper-based systems is that they allow for that individuality, I can't talk today, of clinician practice. So if your clinician likes to do their depression screening first, before vitals are taken, does your system allow for that, or do they have to click through multiple screens to enter that data, which then makes it more complex to get back in to do the vital signs? Think about how clinicians interpret what the various measures are. So do they all have the same belief and understanding of how to order follow-up if the patient is identified to have a BMI outside of the normal range? Or if the patient is a smoker, tobacco user, do they have the same process and follow the same methods for ordering follow-up and ordering cessation counseling? Really have consistent workflows and policies in place, because then you'll make sure that you're comparing apples to apples rather than apples to grapefruits or whatever the case might be, where it just doesn't line up and doesn't match. And then, again, consider the possible variations. I just mentioned that. Documentation tools. We've talked to many ACOs. I work out of the Massachusetts office primarily. ACOs that have practices with all different EHR vendors. So again, that can cause differences in the data that's being reported, even on the same measure, because that EHR just pulls it a little differently. So it's important to compare like sources and like data. And again, is there an opportunity to achieve standardization? So don't take away your clinician's ability to be an individual and have their own workflow, but try to make sure that there is a standardized, recognized, and approved process across as many settings of care as possible, because that will definitely make your reporting much easier. So we talked about this a little already, but complete and thorough documentation. So consider three things. What is the population being measured? So what's your total patients? Is it related to a specific diagnosis? What is the element of care that's being measured? So is this related to a medication being administered, a diagnostic test being ordered? Again, those outcomes. What was the outcome of all those processes? And then is all the data displayed on the report? So again, do that gut test. Does it look correct to what you think it should be? Or do you see that there's some gaps or clearly inaccurate? Obviously, common themes I'm bringing up again and again and again. Hopefully these are all sinking in and you guys see where the data sticks on your reports and how workflow really does determine how accurate and valid your data might be. I just want to talk about supporting documentation quickly. It doesn't quite align with what we were just talking about, but it is your report. CMS does have plans to audit clinicians, and they do reserve the right to audit for up to 10 years after data submission. And in the final rule, if you're familiar with that, there are definitely provisions for randomly selecting eligible clinicians and groups on a yearly basis to perform audits. There are plans for CMS to start doing this. I don't know if it'll be 2018, but potentially in 2019. So with all that in mind, it's really crucial for practices and clinicians to have the data available and the documentation to support what they've submitted. So if you're submitting quality measures or other measures for improvement activities, make sure you have the data reports that you're pushing those numerator-denominator populations from. Workflow documents. What's the process you follow? What's the policy you follow to dictate whatever that given workflow is or documentation is? So when CMS says, we're auditing this specific measure, you can quickly and easily pull your documentation packet and submit it right back to them for evaluation. I'm just quickly going to talk about those quality improvement strategies. I'm thinking, though, actually I want to just for about 3 minutes open up the phone lines in the chat to see if there are any questions. If you have a question, you can press #6 to ask it over the phone, or you can type it into chat. All right, well, I'm not seeing anything, so I'm not going to leave it open for 3 minutes, but, oh, there's one. If we report on claims and submit our advancing care information improvement activity data on the QPP portal, will that be sufficient? Yeah, Amy, great question. Absolutely. So if you submit your claims data for quality, that would cover the quality, and then you do have the option to do manual attestations, or if you have a report, you can submit it for advancing care information and improvement activities right on that QPP portal. You would be doing great, and you would cover all of your bases. All right, I'm going to move on, and we'll have more questions at the end. So quality improvement strategies. The first, and I really like PDSA cycles. Many of you are probably familiar with PDSA if you've been in quality for really more than 5 minutes. W. Edward Deming years ago created this. It initially was the PDCA, Plan, Do, Check, Act cycle, but it's a great, pretty quick way of implementing process improvements and quality improvements into a workflow. So in the cycle, when you plan, obviously you're looking at identifying a problem. So what are you having challenges with in your practice? Is it around patients not doing a certain intervention, or is it about the check-in or check-out process? What's going on? So you can identify your problem and then plan for those possible interventions. And you really want to make sure that you're developing objectives and measures that can easily be measured and monitored to identify when you've hit success and when you may need to change that practice again to get the success you're looking for. As you go into the do part of the process, you're starting to implement those small tests of change. So when you look at those possible interventions in the plan step, you're now implementing them into your workflow and process. But again, these aren't boiling the ocean. You're looking at a small change. So maybe we hand a patient a paper now, and in terms of getting them logged into the portal, and your portal, not the CMS portal, and maybe now we have an MA at checkout, give them the token. Excuse me. For the study portion of the cycle, you're starting to evaluate the data that's coming in from whatever you did as your intervention, and you're measuring it against those objectives and measures to see if there was an improvement. Again, this is a small test of change. You're looking at a short period of time to see if the intervention you deployed really did have the impact that you wanted. Now, sometimes that short period of time needs to be elongated a little to make sure that you have adequate data, right? If you have one point in time, typically that's not indicative of an actual change. You need to have multiple points in time to see how you're performing and see if it does meet your needs and what you want to get accomplished. From there, we have the act. So when you act, you're taking all of the 3 prior steps and you're adapting this new workflow, new process, new plan into the next steps of your whole workflow. So if it was one small thing of giving a patient a paper initially and now you have an MA sit with them, then you're implementing that across the board and making sure it's set and steady and stable in your process before you move on and implement a new intervention. You really don't want to have multiple things going at once because it is really difficult to say, okay, was this the reason we got success and improvement? Or was this the reason we got success and improvement? Or was this the reason we got success and improvement? You need to have one measure that you're kind of looking at initially and then move on from that. Now, I will admit that I know that's not always possible, right? Practices and organizations have multiple competing priorities, and they oftentimes have multiple quality improvement and process improvement activities going on at the same time. But for the PDSA cycle, it really should be one thing. It's meant to be just a small, again, a small test of change before rolling it out to larger, more broad workflows. Workflow analysis, I love flowcharts. I love looking at workflow. This is actually a quality measure flowchart. I can't actually read it right now because it's very small, but I think it's right from the hemoglobin A1C for control. So when you look at workflow, there are two things about workflow analysis. You should start by looking at how your workflow currently is in this moment. So it might not be your ideal, but how are the staff or the clinicians going through the given process right at this moment in time? You map out the current workflow, and then you, again, evaluate those workarounds and any bottlenecks. Where are you seeing issues? Where is the breakdown? Where are the complexities maybe that need to have additional layers of staff added or new documentation tools implemented? Capture data to support what you found and give some idea of maybe where you can have success if you make that workflow change. And then start identifying what your ideal workflow is. So maybe right now everything isn't going exactly as it should be, but what would success look like and how do you map that out? And once you, again, map it out, and then you would want to probably implement a PDSA cycle to implement that intervention to change the workflow, start educating your staff on how the new workflow will go and any new documentation that's needed. It's really important to see how you're doing and how your staff are doing and engage them in the conversation. I was at a CMS quality conference the past couple days, and there were two key elements that were highlighted. One, having clear patient voice in your process and in your workflows and in all that you do, and also making sure that clinicians are included in the decision-making. Because if clinicians are not included, oftentimes the process is much more challenging. It results in burnout and dissatisfaction. And so really trying to make sure your clinicians are engaged in that whole process, start to finish, to make sure that it meets their needs. Oh, somebody's not muted. Do you mind muting yourself? The next thing I want to talk about is root cause analysis. So this is also a really nice tool. It can be a pretty quick process, and it can also be implemented along with the PDSA and the workflow analysis tool. So initially, you define your problem. So you need to look at a specific event or outcome. Maybe it's trouble with the check-in or check-out process. Look at pulling the qualitative and quantitative data to support whatever that issue is, and then start planning for advanced care, planning for patients. That's not supposed to be in there. I wonder how that got there. Anyway, next, gather the data. So identify the who, the what, the when, the where, the why. Look at all elements that are part of whatever the event or issue is that you're evaluating. Look at the casual factors in the gaps and deficiencies of knowledge. So you want to start thinking, was this just a workflow, again, that wasn't followed exactly as it should have been? Or is there knowledge deficits that need to be addressed? This can be a great time to complete interviews with staff. So, again, getting that workflow analysis, what do you do now? Or where do you think the issues might be? And having staff openly and honestly tell you about what they think might be wrong can oftentimes help tremendously in identifying options for improvement. Next, as you identify the root causes, you kind of gather all of that data that you had in the previous step, pull it together, and look for trends. Look for reasons why the process might have not worked exactly as it should have been, and where the failures might have been. And then again, consider the system-level failures and processes. Maybe it wasn't anything to do with one staff member or group of staff members or part of the process, but more of an overall system-level issue where something isn't linking correctly or it's just not working out quite right. And consider all of those as you move on to the next step. Next, you'll identify those interventions for corrective action. So again, consider what the cause was, consider what might work in terms of corrective actions. Again, this is a great time to do a PDSA because oftentimes you don't want to go in with guns blazing and a whole system of things to change. You want to go with one small change and then see how that works and then implement another small change and see how that works. Next, you'll implement and monitor. So then you'll put in those changes and then you start to monitor. And if you receive success from what you did, great, you can move on with the process. If you evaluate it and you see that, in fact, you didn't reach the efficiencies and improvement you wanted, then you can start the whole process again and identify, okay, clearly that was not the root cause or that was not the appropriate corrective action to take in order to improve the situation. I would be remiss if I did not talk about provider education. So obviously all of this has to do with providers and clinicians and how we work with them and engage them in the process and the education. So thinking about this, what are the measures of importance to those providers and clinicians? So again, having the clinician voice. We know that there are multiple competing priorities. We know that the systems are often very complex, but having those elements of what really is meaningful to the provider and the patient can help inform the process tremendously. I mentioned it a little earlier, but how is your performance data being shared with those clinicians? Do you kind of just hand them a pile of reports and say, here's your data for the month, which I'm sure none of you probably do, or do you hand them a nice graphical representation of their performance that shows clearly they're doing well on these measures and not so well on these measures, and then talk about potentially adjusting workflows or corrective action or interventions? Again, I already said it, but are there multiple competing quality improvement projects underway? This is where it can get very confusing and cumbersome for the clinicians because they're being asked to check 15 new boxes and document in a new note template and make sure the patients receive X, Y, and Z as handouts. So really take into account what's being asked of the clinician right now and where you need their improvement to go in order to see what you want to see on the quality data report. But it might be a simple thing just to say, hey, can you add this to whatever it might be, general example. And then do you have provider and clinician education sessions that accommodate varying shifts and schedules? We know clinicians oftentimes have a lot of trouble getting to education sessions that take place during clinical hours or right, at the start of the clinical day and end of the clinical day because they're trying to get their notes and patients ready to go. So do you accommodate their schedules and different shifts? Sometimes having nighttime meetings or very early meetings can be a useful tactic. I'm going to open it up for questions. Those of you that have been on presentations of mine probably know that I always have pictures of my dogs. We have added a new family member. The middle one is our newest addition. That's Boris. He's a little baby pug. But I welcome all of your questions. I see some in chat, which I'll get to right now, but if you'd like to ask it over the phone line, it's #6 to open your line. So first question is from Lucy. At the end of the session, can you address for those of us who have reported 2017 on the QPP site utilizing our EMR, why under the improvement activity category score it's not calculating correctly for for those of us who have a small practice banner? So Lucy, I just heard about this just a couple days ago from CMS. They are working on getting the algorithm correct to give the small practices the appropriate number of points for the improvement activity category. So for those of you who aren't sure what Lucy is referring to here, small practices have to report on fewer improvement activities in order to receive full credit in that performance category. But the way that the CMS portal is currently laid out, even if you're identified as a small practice clinician, it's not appropriately giving you full credit if you've performed one high-weighted activity or two medium-weighted activities. So I would say keep an eye out. I know they are actively working on a fix, and I would hope that it's in place maybe in the next week. If you don't see anything, please let us know, but I know they are working on correcting that. Unable to find the slides. Morgan, do you mind posting the link for the slides again? Lucy also asked, when will CMS let us know what incentive we may get with an 80% score? So yeah, another great question. I know CMS is working on, obviously, we're still in active data submission time. So once data submission has ended, March 31st, CMS will pull all of the data that you had all submit, and they'll start doing their performance evaluations. I know the target is to have performance reports available sometime this summer. I think I've heard July as a rough time. So it'll be, I'd say, sometime between July and September that you would know where your performance got you for the positive payment adjustment. And then obviously those payment adjustments would be made on 2019 Medicare Part B. Another question, I understand that we need to engage and involve our providers, but how do you do this in measure areas that they don't feel are relevant to their specialty? Yeah, great question. I think that's like the million-dollar question, right? How do we get our providers engaged when it's difficult? Do you mind sharing what specialty clinicians you work with? I will say CMS is looking into ways to add more specialty-specific measures to be more appropriate to given provider groups. Now, that doesn't happen overnight, so obviously there's different areas that they're focusing on, and I just want to say, if you work with clinicians that feel that they're underrepresented in terms of measures, CMS really welcomes clinicians and clinician groups of specialists to recommend measures, work with your specialty society or whomever has the evidence-based practice in place to make measure recommendations, because CMS does welcome those, and they do want to make sure that there are measures appropriate for all clinicians. So Lucy mentioned urology. Yeah, urology has a very small subset of measures. I would say for quality, it's going to be tricky because those measures really don't apply to them oftentimes. But there are those cross-cutting measures. So those are measures that really apply to any clinician with any practice type. Now, specialists might say, I don't do this or it's not appropriate, but in fact, they should be. So things like assessing patients for tobacco use, really all providers should be assessing patients for their tobacco use and then providing cessation counseling. Another that's been pretty hot topic this year has been influenza immunizations. So while you don't necessarily have to have your clinicians providing the influenza immunization to patients, you do need to at least ask them about whether they've received it or not and then document it in your system. So oftentimes patients might go to a local pharmacy and receive it. If you document that in your system, you would get credit for it. The other, that's a great one that a lot of clinicians do and I think sometimes slips through the cracks, is utilizing the documentation of current medications on the chart. That's obviously one that pretty much every clinician would do, where they're asking patients about their medications and then following up. Another is the advanced care planning, where you are documenting that the patient has a healthcare proxy or a living will that they can go to and get information about how the patient would like to be cared for should they be in a situation that they need end-of-life care. So I know that's a very roundabout kind of generic answer, but there are measures that do cover a lot of specialties, even if they're not specific to that group. And I would just say these are kind of general care measures that really all patients and all providers should be talking about. Christine asked a question, just to add to the 80% score question answer, the clinician will receive 4% plus a minimum of 0.5 for an exceptional performer bonus, probably the higher of the score, 70, the more the bonus score, greater than, yes. Yes, that is correct. So the exceptional performer bonus, it's over 5 years. It's a bucket of $500 million that CMS has set aside. So it's about $100 million, I can't talk today, set aside per year. If you hit that MIP score of 70 plus, you would be eligible for an exceptional performer bonus. As Christine mentioned, if you're in the 80-point score range, you would receive more of that exceptional performer bonus. It is a calculation about your total score, your total claims. There's an algorithm that takes place. So it varies. It also depends on how many clinicians are going for that exceptional performer bonus, how that money gets allocated. So more to come on that. We don't know how it will all shake out once data submission has been completed. How will we see the performance bonus on the EOB? I believe you will not necessarily see it on the EOB. You'll just see it in your claims coming back, so those payments. And I don't know that CMS will actually even denote that it's your performance bonus. You'll just see a slightly higher rate. Any other questions? For those of you who have questions that don't want to necessarily ask them now, we have some resources. So this is our New England QIN-QIO macro page. We have a link to resources there. You can also ask the question directly. These are the CMS tools, great participation status lookup tool, and the CMS portal if you need to still submit data. If you have a question you would like to ask for me directly, please feel free to email me. Actually, I want to also provide you with some PDFA resources. I just entered that into chat, but you can email me. I see one more question. Do you think those general care measures will be topped out, thus requiring a higher than 90 percentile for higher points? Is this more desirable to attempt the lesser used measures? Yes, that's a great question, Stacey. So you're right. Those measures that I mentioned definitely are getting to the topped out point. Just for the current rulemaking, CMS has identified they're doing a 4-year phase-out for topped-out measures. There's 6. They're very specific to certain specialties, and I apologize, I can't recall what they are for this year. Because those measures, the tobacco use and cessation counseling, advanced care planning, the medication management, because those are really cross-cutting measures and there are not a lot of them, I don't think, even though typically clinicians are performing very well on those, I don't see them getting topped out and removed anytime soon. There will obviously be changes to the benchmarks in coming years based on how clinicians perform this year and next year. So I can't speak to what the actual performance thresholds will be, but it's really up to you and your clinicians what you think works best. It's, again, important to make sure that those measures are meaningful and that you can perform well on them, but I wouldn't start thinking that those measures are topped out and thus to stay away from them. You most certainly can still report and still do well, even if you're reporting high rates. So just a couple of minutes left. Any last questions? I did want to mention we also have New England QIN-QIO Patient and Family Advisory Council. This is a great resource if you want to have a documentation tool or patient education tool evaluated. Our group is great at giving feedback on workflows that might make sense for patients or not make sense for patients. So feel free to reach out to us. We'd be more than happy to have them assist you in your practice and quality improvement. And we also have some social media tools. We're on Facebook, LinkedIn, YouTube, and Twitter. If you would like to look up any way that we have made different materials available, or if you would like to see what events we're going to, and we also post other outside reference materials, those are great resources to check on. 2 minutes left. If you have any last questions, feel free to ask them in chat, or if you'd like to open up the phone line again at pound 6 to open up your line. We will be sending out, I see a couple of you are having trouble getting a hold of the slide deck. In the next day or so, we will send out a follow-up email with the links to the various materials. I apologize that it's not working right now, but we'll make sure that you get those. So hang tight. If you were on the registration list, you will get that in a day or so. And it's 12:30, so thank you all for participating today. And again, if you have any questions, please feel free to reach out to me. We're here to help you and make sure that you're successful.